Yeah. Okay. And you see low magnification, there's a small little bit of the quantified layer up here, and there's a blister. So it's a blister that's within the epidermis, and if you go to higher magnification, we can see that it's an intra-epidermal blister. You would have thought that at low power anyway. And then we see that it's very acantholytic. So it's an intradermal acantholytic vesicular dermatitis. So, the differential diagnosis of that includes the diseases in the family of Pemphigus. So we have superficial Pemphigus, Pemphigus vulgaris, Haley-Haley disease, pseudo-Pemphigus, things like drug-induced Pemphigus, after Pemphigus form of Grover's, localized small area of involvement. So we have to decide which of those it is. And if you look over in this area, this is an important teaching point. You've got the suprabasilar cleft here, the residual row of tombstones overlying it. So when you see this, especially at the edge of the blister, this is almost like an artifactually induced blister from the punch. That is very suggestive of Pemphigus vulgaris itself. I'd say, well, you know, you read the textbooks and they talk about dilapidated brick wall or Haley disease and all this kind of stuff, and if you just had this area, that could be somewhat difficult to distinguish from Pemphigus vulgaris here. So a good teaching point is that sometimes in PV you get acantholysis throughout the epithelium, and if you look to the side, you see this change, that's almost never seen in Haley-Haley. So this you don't ever get in Haley-Haley, but this you can get in Pemphigus vulgaris. The question is whether you get dyskeratosis, and you generally do not get very many dyskeratotic keratinocytes in Pemphigus itself. Sometimes in Haley-Haley, but notice that there really are very few dyskeratotic keratinocytes here. This is Pemphigus. Maybe one there, but not a lot. So that's helpful. The other thing is if you see a hair follicle that is involved, that favors Pemphigus vulgaris. Grover's disease does not get into the follicles like this. So if the differential is Grover's and Pemphigus, you see follicle involvement, far more likely to be Pemphigus rather than Grover's. Haley-Haley can involve follicles, yeah. So that doesn't help you there so much. But that, again, you wouldn't expect to see that nice little sort of tombstone type.
It's being pressure a little slow.
Okay.
Park a little bit more than normal.
Okay. Okay. Now this next case, we have Dr. Morrison here. She's kind of an expert. Oh, we'll show the clinical photos. Let's go back there. We'll show what the pictures look like with Pemphigus. This is a nice example of Pemphigus. Notice the diffuse involvement. Haley-Haley does not generally involve the skin in widespread fashion like this. It's usually localized to intertriginous areas of neck, groin, underneath the arms. So there's another picture. Okay, for those of you dialing in, you're going to take the board examinations. Make sure you know the next slide possibly, which talks about the desmogleins and whatnot. Next slide. So you want to make sure that's desmo, L-I-E-N, not L-I-A-N. So you want to, in direct immunofluorescence, you're going to see intercellular IgG and C3. You would not see that in any of the ones below. But okay, let's look at 152. This is the one that Dr. Morrison is kind of an expert on. So this is, if you look at this at low power, you see this nodular neoplasm. It's not contiguous to the epidermis. Apologize for the folds in the tissue, but that sometimes happens when you get a big giant piece of tissue like this. So there's nothing in the epidermis. It's sitting in the subcutaneous fat. And you see that pattern, it kind of makes you wonder if it could be a metastasis of some sort. I'm not sure in this case whether it really was a metastasis. I personally tend to think it probably was.
We actually did get history on it.
Well, there's some history, but history is sometimes right.
Well, and follow-up. So this patient had this lesion on her side of her scalp for a while, like 15 years, and then she had a neck mass that grew up kind of rapidly over a couple months. So
it's possible it
she
could have been
had
living in her fat for 15 years.
removed, and then she had an entire body scan and lymph node dissection. And this is the primary.
This is supposedly the primary. But, a lot of people believe in Santa Claus also, so I'm not going to say it's impossible, but it really sort of defies, for a clinician like me, to see a big nodule sitting down here in the fat. And that's been present supposedly for 15 years. It's pretty unusual. It's been 15 years, it's been growing for 15 years, because this, I guarantee, didn't start off this size 15 years ago. Anyway, you can see that it is a epithelial neoplasm. So the differential diagnosis includes primary adnexal carcinomas, but you start looking at this, you see the cells really don't look like the typical small cuboidal monomorphous cells or things like a poroid hidradenoma or anything like that. Yeah, it does look like there might be some vascular invasion. There's some necrosis on moss. This is a sign of malignancy when you get cells like that that just kind of die in a little group like that. It's a mitotic figure, probably in maybe, I don't know which phase, but it's certainly the nucleochromatin prophase probably would be good for that. So it's malignant. It's very deep to the skin, and it doesn't look like any typical cutaneous adnexal neoplasm. So this actually turned out to be a low-grade neuroendocrine carcinoma, right, Annie?
Low-grade neuroendocrine tumor.
Low-grade neuroendocrine tumor,
Formerly known as
carcinoid syndrome.
carcinoid tumor.
Carcinoid tumor, I guess, yeah, carcinoid tumor. Did she have any carcinoid syndrome?
No, so because the way that these, if they are active in secreting hormones or that they're metabolized, they don't actually display carcinoid syndrome unless they have mets to the liver that compromise the liver ability.
So she did not have any actual syndrome, so we don't know whether she
But this
actually
was a this tumor did pick up on an octreotide scan, and that's how they found that this one lit up and then the lymph nodes lit up.
Okay, so she had lymph nodes involved and then had this. So I'm wondering, again, I had a patient come in one time that had a lymphoma the size of a softball. He told me that it had been there just a couple of days. He had a huge giant Band-Aid on it. I remember those resins. It's like you never forget. So I'm just wondering, this patient may have had an occult carcinoma somewhere else, had this, it is low grade, metastasized to this area, never found the primary, maybe even underwent regression in her GI tract. Because things from the GI tract like this like to go to the scalp. The scalp is a very common site of metastasis. Breast goes here, kidney goes here, thyroid goes here. So things love to go to the scalp because it's so vascular. So from a clinical perspective, it makes a heck of a lot more sense that this was a primary lesion, a secondary lesion. Let's take a look at the slide. So this would have just been a bump in the skin, maybe not even any color to it. And so basically, if you like new names, you can now call this a low-grade neuroendocrine tumor. I still like carcinoid. So the main thing here was that the stains were of interest. It was positive for some of the stains that we use for neuroendocrine differentiations, naphthophosphate, chromogranin, etc. Why is CD56 positive, Danny? That's kind of interesting, isn't it?
It's lumped in with the neuroendocrine markers. It's probably the least specific of these three.
Is that also same kind of neurofilament-like things too, supposedly, or no?
It's more of a neuroendocrine.
Okay, and then CK20, tell us about that. That means it occurred below the diaphragm primarily, possibly? Or?
CK20 would be positive if this is a Merkel cell. So Merkel cell is the cutaneous manifestation of a high-grade neuroendocrine carcinoma.
So we know that it's.
So this was CK20 negative, so it's not a Merkel cell, which would also make sense because it did not have the cytologic features of that kind of malignancy. Additionally, it had Ki67 staining of about 2.5, 2.8%, so it was less than 3, so that by definition put it as a low grade. If it was between 3 and...
That's good enough. Thank you very much. We'll move on to the next case. Okay. We're going to shave biopsy, and at low magnification, you can see that there is an infiltrate of some sort, a patchy, sort of band-like fashion dermatophymal junction. Notice that there are things going on in the epidermis here. So at low power, you see collections of cells in the epidermis. Think of things like melanocytic differentiation, It could be pagetoid keratinocytes. Could be Paget's itself, yeah, as Mokhtar mentions. Or they could be lymphocytes. And as we go to progressively higher magnification, you can see that indeed they are lymphocytes, and they're forming little so-called Pityriasis collections in the epidermis. Pityriasis collections. Pityriasis was a Frenchman. Yes, he was. He was in the 1800s, as I recall. I would have to look that up to see. But anyway, this is a very nice example of Mycosis fungoides. Now, there are several other teaching points here. First of all, notice that you've got lots of cells with minimal spongiosis. You can get spongiotic dermatitis with collections of lymphocytes in the epidermis also. Not usually this many. Large cluster like that. That's unusual for one of the primary spongiotic dermatitis to get that. There's another one over here. And I was going to mention EOs. You can see lots of EOs in Mycosis fungoides. So that doesn't rule it out. Just like you can see a lot of EOs in lymphomatoid papulosis, you can also see quite a few EOs in MF. So that's not a helpful distinguishing feature all the time between that and contact dermatitis. Notice that the collagen bundles are quite thick. Dr. Ackerman used to refer to this as the fettuccine sign, because they look like thick strands of fettuccine, and that's a sign of chronicity. Anytime you put a lichen infiltrating the skin to leak there a long time, it turns the collagen thick, and eventually that's associated with atrophy, superficial cigarette paper wrinkling atrophy with telangiectasias and poikiloderma. There are also a couple of plasma cells in here. So just because they're plasma cells doesn't mean it's not Mycosis fungoides. So don't let these things be extraneous factors in making an accurate diagnosis. Okay. One other thing that's helpful, you don't always see Pityriasis collections in MF. And when you don't see them, you can also look for another helpful finding. That's single cells lining up at the basal cell layer. It's very characteristic of MF. And the cells in the epidermis tend to be larger. That's kind of a convoluted cerebriform cell there. They tend to be larger in the epidermis than they are when they're in the dermis. It's not 100% true, but it tends to be true. Just think of them as when they get in the epidermis and kind of swell with pride a little bit. But that's a pretty large atypical cerebriform lymphocyte right there. There's another one, looks like somebody's brain there. So, Mycosis fungoides. Now, we sometimes like to we try to decide what stage the MF is based on histology. This still clinically might have looked like a patch, but it's a little denser than most patch stage disease, which super early is a very sparse perivascular band like infiltrated epidermotropism. Okay, let's take a look at some pictures. So here we go. Large reniform plaques. This would be more of a plaque stage MF clinically. Okay, of course you can treat it with all those kind of things there. Next slide. And then the histology is pretty characteristic. Now, some people like to use immunostaining on this. The CD4 CD8 ratio is much higher, CD4 to CD8 cells, although you can get CD8 positive Mycosis fungoides sometimes. So again, I don't use those all that much personally. And then you can get clonality. Usually by the time it's a plaque, it's pretty common for that to be present, but some of the early lesions may be negative, T-cell killer. All right, 154. Okay. All right. Punch biopsy. Superficial perivascular dermatitis. We notice little mounds of parakeratosis here. I think 5 of them right there. Pretty. And most of these cells, even at low power, you can say they look like lymphocytes. Mostly superficial perivascular. So the differential diagnosis of superficial perivascular dermatitis is long. So the longest of all the patterns. So you have to use other features to help you make a diagnosis here. In the presence of these mounds of parakeratosis with no neutrophils in them, with scattered lymphocytes in the papillary dermis, with a little bit of spongiosis, not spongiotic microvesiculation, really very nice example of Pityriasis rosea. So this is a gorgeous, beautiful example of that. Now, usually it's about 95, 98% lymphocytes, like here. Just like in anything, you get exceptions to the rules, and there actually is an eosinophil here. So just because you see a couple of EOs, don't just say, oh no, oh my God, it can't be PR because there are a couple of eosinophils. So it still is PR, especially in the proper clinical context. You might say, well, what about a Pityriasis rosea-like reaction to gold? Well, yeah, it can look exactly like PR. Drugs can do just about anything. So if you had a history of the patient taking a medication, you might possibly suggest that it could be a PR-like drug reaction, especially with a couple of EOs, because it's less, you don't usually get too many EOs in PR. What about a viral xanthan? Could that look like this? Well, the answer is yes. PR probably is caused by a virus. So, yes, viral xanthan could look very much like PR. What about if you biopsy the Herald patch of Pityriasis rosea? This probably was one of the small little scaly lesions of the Christmas tree pattern on the person's trunk. If you biopsy the Herald patch, that often gives a superficial and deep infiltrate and looks more like one of the gyrate erythemas. So you can get scale in that too, yeah. Herald patch is scaly, so it can give you the same type of cornified layer. So it can look almost exactly like erythema annularis centrifuga. So if you get a Herald patch, that's the differential diagnosis of that. So this is a nice example. Beautiful. Gorgeous cut. Gorgeous histology. Doesn't get better. Let's take a look at the clinical, and here's an example of that. There's the nice, beautiful Herald patch. Annie's showing right there, and then the widespread eruptions the rest of the body. Now, clinically, syphilis always comes in the differential diagnosis. 30% of the cases you get palm and sole involvement with PR. So doesn't rule it out if you get palm and sole involvement. I have seen the histology of syphilis look very much like PR, so if there's a question, you can always do the serology or so here's the clinical on that, pretty straightforward. And then let's look next to show basically what we saw. Guttate psoriasis generally will give you mounds of parakeratosis with neutrophils as opposed to no newts in PR. Rare to see newts in that. Okay, let's take a look at the next case. All right, so we've got a shave biopsy here. So probably thinking of a neoplasm. At low power, it looks like there's a really, really dense inflammatory infiltrate. So whenever you get a dense inflammatory infiltrate, obviously the first thing is to think about an inflammatory disease. One of the inflammatory conditions are lymphoma, pseudolymphoma, something like that. But then always ask yourself, well, could it be a neoplasm that's severely inflamed? So that's an important thing to always remember. We always look at everything first without any history, just like we're looking at the history right now. Make up our mind at low power and then at progressively higher magnification. Then we look at the history. Because unless you have a pretty bad case of short-term memory loss, if you look at the history, you're going to be biased almost immediately. So I strongly recommend giving it an evaluation with no history, then look at the information that you're provided, which hopefully is at least enough to get something to help you with, and then make a correlation between those two. And here we see at higher magnification that there is a neoplasm, and it's comprised of nests of cells, and they're at the dermal junction where they're a little bit sort of epithelioid and spindle in shape, and then here they're more round, typical, and then with the very dense inflammatory infiltrate, saying, this looks like a nevus that's severely inflamed, and it's a little bit spitzoid right here. So, somewhat spitzoid. So you might say, well, okay, I'm going to make the diagnosis of a halo nevus. Well, I would encourage you not to do that, because if you do, the clinician may call you up and say, what do you mean, halo nevus? There's no pigment change here. Not a halo nevus clinically. Histologically, you can get nevi that have lots of inflammation, and there's not one single bit of depigmentation on the patient, no halo at all. And the reverse is true. You can see what looks like a common intradermal or compound nevus with not one lymphocyte, and they've got a marked halo clinically. So there's a clinical pathologic discord between what you see clinically in halo nevi and what you see in the microscope sometimes. So in this case, it was a halo nevus. Halo nevi tend to give you this very, very dense infiltrate, and sometimes the infiltrate is so dense it obscures the nevus cells altogether. You might even have to do a special thing to see that they're there. We have a clinical photograph of halo nevus here. And if you do a Fontana-Masson stain or an S100 stain of the halo area, it's like vitiligo. There's no melanocytes there. So the inflammation wipes out the melanocytes in the halo. They may eventually come back over the course of time. But that's a nice example of that. And sometimes you get a lot of inflammation, sometimes you don't. Sometimes it's a little reddish, but a lot of times it's just totally white. And you don't have to remove these clinically. If they look like that, they're totally benign, nothing needs to be done, they're not melanoma. Be careful because sometimes the inflammation makes the cells look a little larger and slightly atypical. Usually you don't see many mitotic figures. If you start seeing asymmetry with mitoses and pagetoid spread, consider the possibility that you're really dealing with melanoma. But generally, in fact, all the time, halo nevi are benign. They don't need to be excised. They're not melanoma. I've seen cases called melanoma inappropriately. And one other thing about halo nevi, sometimes you get eruptive halo nevi in patients that have melanoma. So if you get a lot of halo nevi, be careful the patient doesn't have melanoma somewhere else, maybe undergoing regression, and it's a secondary inflammatory infiltrate due to the patient's melanoma. So, nice example of halo nevus. All right. It's a shaved biopsy of a little pedunculated papule. And even at low magnification, you can see that there's this very pale stroma that's probably got some mucin in it. And then you have a higher magnification, you can see these cells are somewhat round and a little bit spindle. And as you go to even higher magnification, you see this sort of delicate, lazy S-shaped morphology to some of the cells, like here. And there's a mast cell right there, which goes along with that somewhat fibromucinous stroma. So this is a beautiful example of a neurofibroma. Here's the nice example of these little sort of delicate S-shaped cells here. These are Schwann cells. Okay. So this is a beautiful example of a neurofibroma. Not anything special about this neurofibroma. It's not a plexiform neurofibroma. It's just a garden variety papule of a neurofibroma that may just be present coincidentally, probably not, but could be associated with neurofibromatosis. Now, if we saw a plexiform neurofibromatosis, those are almost always associated with neurofibromatosis. So when we see a plexiform lesion, we mention that in our report because that's a marker of a cutaneous syndrome, a systemic process. So if you see plexiform, be careful. If you see only just a solitary one, you don't have to be as careful. So if you're taking a board examination, they may show you something as easy as this and then put a few other things down there for you to have to choose from. They might put a neurolemoma, for example. They might put a palisaded encapsulated neuroma on there. They might put a leiomyoma, thinking you might think this is muscle as opposed to nerve. So a neurolemoma or schwannoma is usually associated with, there is a myxoid or one type that's the Antoni B type, which can look a little bit like a neurofibroma, but not quite to this degree. Usually always you'll see a little pre-existing nerve twig at the side. That's because the way those lesions develop is from the outside of the nerve that then kind of grows like a little knob on top of the nerve. This actually forms by the process occurring within a nerve twig and kind of exploding out. So it's a nice way to think about these. We've got a picture of one up there. Okay, it's got about 4 of them. That guy actually might have neurofibromatosis here. And they also look like skin tags. Usually come in as nevus or something along those lines, pretty straightforward. So if you've had something like that on the exam, hopefully by now you'd be pretty good at making the diagnosis pretty quickly. Okay, something completely different. Got a large lesion with multiple pieces of it. So the clinician probably took about 2 or 3 chunks of this and stuck it in a bottle. You see at low magnification, it's sheets of these cells here. They don't look like inflammatory cells. They look like they're neoplasia, neoplastic cells. It's hard to tell at low power exactly what they are. They might be epithelial because they're pretty closely opposed to one another. This also looks like it's sitting maybe in the dermis. There's a little bit of an ulcerated area right over here. But this could be something that's involving the skin secondarily. There's a little bit of a, possibly a little grin zone right here, but there actually may be something in the epidermis here. So as you go to higher magnification, you now see that there are nests of cells or single cells in the epidermis, so that favors a diagnosis of a melanocytic process. What's kind of interesting here is that you've got some large multinucleated cells here, which are interesting. It's very interesting for this lesion. But you've also got this change in the epidermis. And another thing that you've got here too is extensive necrosis. So right over here you've got necrosis on moss. Whenever you see necrosis on moss in a melanocytic neoplasm, it's pretty much melanoma until proven otherwise. Nevi do not undergo necrosis on moss. Even when they're traumatized, they don't necrose like this. So this is tumor necrosis factor at work here. It's very interesting because it's got these large cells, and you kind of wonder, it's possible that this may have been a lesion that was a congenital nevus that degenerated into melanoma. And a lot of these sort of Teuton-like multinucleated melanocytes could actually be some of the pre-existing cells of the nevus, because you can get those kind of cells sometimes in giant congenital nevi. So there's several different types of melanocytes, that 8 types: large, round, small, round, patch-jointed, balloon, oval, spindle, dendritic, multinucleated. So these were multinucleated melanocytes, and that pattern looks a little bit different than the necrotic area. I don't know if we have any follow-up on this patient, whatever happened to this patient. This is really a nasty-looking process with this much necrosis on moss. So it's really an interesting case. And there's some mitotic figures in this thing also. Really very interesting case. I suspect this probably was congenital nevus that degenerated into melanoma. I think we have a photograph or two up here. So this probably wasn't what the lesion looked like, but obviously if you ever see that clinically, you need to be concerned about it. And then basically if you see a melanoma that's ulcerated, this necrosis usually is associated with the ulceration. Okay. So remember, necrosis on moss, think of melanoma. All right. Another shave biopsy here. It's got a lot of vascular spaces. There's a lot of thrombosis, and there's also some verrucous epithelial hyperplasia. So it kind of looks like if you took away this vascular component, just looked at it silhouette, you'd say, gosh, it looks kind of like a wart. It probably would have been verrucous clinically, epithelial hyperplasia. And then you've got these large vessels in which there's thrombosis within these little vascular spaces. So this is a vascular neoplasm. It's benign. It's got these verrucous epithelial hyperplasia. And it's got this thrombosis in here. So it looks a lot like an angiokeratoma that was traumatized and thrombosed. Usually just hemangiomas they're not situated quite that superficially along. The differential diagnosis could include a hemangioma and a lymphangioma kind of hybrid, if you will. That's thrombosed too. Usually you don't get this many blood vessels in a lymphangioma that's got a hemangioma component. So we call this an angiokeratoma that have been thrombosed. So the thing about angiokeratomas is they're often associated with systemic illnesses, Fabry's disease, L-fucosidosis deficiency. So if you get a diagnosis, or the board might show something like this, and they might expect you to know pretty quickly that it's an angiokeratoma, and then expect you to know the associated illnesses that can go along with it. I think we have several pictures of that. There's several different types. There's the widespread type, there's solitary type, there's the belly type. Or in the scrotal area can look like frog spawn with red cells in it. So, or caviar spots, I think we call it. So they don't have to be removed, but the main thing is just make sure you're not missing one of these other diagnoses. So that's angiokeratoma. All right, number 159. Okay, so we're going to shave biopsy here. And there's no adnexal structures. Also seems to be a diminished granular cell layer. There is some purulence in the upper part of the epithelium. And so whenever you get neutrophils in the upper part of an epithelium or in the cornified layer, the differential diagnosis includes a relatively small number of things. You think about infections, about fungal infections, either candidiasis or dermatophytosis, sometimes bacterial infections, and then psoriasis. Some forms of irritant dermatitis can give you neutrophils in the cornified layer. So you get neutrophils and other things like syphilis, Pityriasis, lichenoides, but usually associated with perikeratosis. So when you see something like this, and this is probably from the mucous membrane site, you can begin to see there is something in the upper part of the epithelium. And it's all these hyphal elements, or actually they're probably pseudo-hyphae. Notice that they're oriented mostly at right angles to the epithelium. They're actually growing into the epithelium down here. So this is Candidiasis. Nice example of that. If you didn't have the organisms and you just had this, you would also think about pustular psoriasis. It's possible to get pustular psoriasis and candidiasis in the same lesion. Whenever you see lots of candida like this, though, it's best to go ahead and treat the candida first and see what's kind of left over thereafter. The other thing that can sometimes happen is you can get marked verrucous epithelial hyperplasia, get so-called verrucous candidiasis. It can look like a cancer. Very, very hyperplastic. You don't want to call it a cancer if they've got a lot of candida in there, because it's just going to come back. And I've seen guys have their lips cut off for benign inflammatory conditions. So you don't want to make sure if you get that diagnosis, you want to treat it first and make sure that you get rid of the candida and then see what's left over. Now you can get a squamous cell that could be superimposed infection with candidiasis, so don't just, you're not out of the woods if it looks atypical, but just be careful of overcalling it. Notice the inflammatory infiltrate, a lot of plasma cells. You get lots of plasma cells anytime you're on mucous membrane. Russell body, it's immunoglobulin present inside that plasma cell, takes on a pink color. Excuse me. Okay. You may get some eosinophils in the infiltrate. You may get some polys. So notice that there are more polys up top than there is infiltrate down in the lamina propria here. So this is candidiasis. I think we have a nice picture of that. There's several different forms of this clinically. You can get this pseudomembranous candidiasis. It looks kind of like leukoplakia or like lichen planus. You can also get erosive erythematous candidiasis. You can get Perlesh, get the verrucous type we mentioned before. So there are a lot of different types of candidiasis, pustular candidiasis. So a lot of different clinical manifestations also. Mucocutaneous candidiasis, you get verrucous epithelial hyperplasia around the fingers and toes. Next slide. So again, hyphae-oriented perpendicular to the mucosal surface. You may actually have some yeast still that may not all be germinating like it was in this biopsy. Okay, next. It's a very common entity that we see in dermatopathology. It's a biopsy again taken from near volar skin. Notice that there's no adnexal structures. There's marked thickening of the cornified layer with a markedly thickened granular layer, and the lamina lucidum in here, I think, a little bit. And then you've got this collection of mucin centrally. Okay, let's go to higher magnification. See the mucin to better advantage. And then you also see these little small stellate fibroblasts associated with it. And you might see a mast cell or two in here. Anytime you get lots of mucin like this, you're going to see an occasional mast cell. So this entity is one of the entities in dermatology and dermatopathology that is a misnomer. There's a mast cell right there cut in horizontal section. It's like a hot dog. And these are these little stellate fibroblasts here. This is called digital mucous cyst, but as you can see, it is not a cyst. It does not have a true epithelial lining like a cyst. These are some fibroblasts and some collagen and dermal collagen that's likely just compressed at the periphery of the mucin that's accumulated here. So the pathophysiology of this process, it's almost always associated with underlying arthritis, usually osteoarthritis. They may have a bone spur. And these fibroblasts that normally produce the joint space mucin, the hyaluronic acid sitting in the joint space, become hyperactive and produce the same joint space hyaluronic acid in the skin. You get a little bump. And it looks like a translucent papule. It's often thought to be carcinoma sometimes by clinicians that don't know any better. Most of the time they get this diagnosis correct. They're just biopsying it just to confirm the diagnosis. But it's not really a cyst. It's actually digital mucin collection. And if you were to do an x-ray on this patient, chances are pretty good you'd probably see a little bone spur or something like that underlying it. I think we have a picture of this. So if you excise this, quote, cyst, it may just come right back. You can cut out all the fibroblasts and all that kind of stuff, and it may not come back, but it might. The other thing that often happens, you can go back to that picture as well, you can see that that nail is sort of depressed. The common location of this is in the nail matrix area, and this mucin compresses the matrix epithelium, and the nail doesn't grow as robustly right over the area where the little mucin collection develops. So you get a sort of a gully in the nail plate there. And if you remove the lesion and it goes back to normal, sometimes that will gradually come back to normal, but often it doesn't. It's often a permanent nail deformity that develops as a consequence of this. And the next slide, I think, just talks a little bit about this. So, yeah, you pierce this stuff, it's kind of like a clear jelly that comes out, and sometimes if you pierce it multiple times, you have fibrosis and scar tissue that it kind of goes away. But usually the treatment is to do some type of an excision. So anyway, it's pretty straightforward. Really not much in the differential diagnosis. Ganglion cyst looks exactly the same as this, only it occurs in a different location. All right, 161. Okay. Shave biopsy, the dome-shaped papule that looks like it's epithelial, and it's mostly epidermal. So this is probably an epidermal, mostly kind of sessile papule, probably with a verrucous papillated surface to it. So low power, it looks very much like a wart. And if somebody would say, well, this came from, say, the genital area, you'd say it might be condyloma. So why are we wasting your time showing you something as boring as a condyloma? Let's go to higher magnification. It's got some other interesting findings. It's got close crowding of the nuclei. And in some areas it's got some large cells that are atypical and in mitosis. Right in here, for example, you've got really close crowding of nuclei with mitoses and atypia. Another mitotic figure over here. So this is HPV-associated carcinoma developing, squamous cell carcinoma in situ developing in condyloma. We use the term Bowenoid papulosis for that, usually associated with HPV 16 and 18, a couple of others, but those are the main ones that are associated with it. So If you see condyloma, you really need to take a look at it and see if it's got features of squamous cell carcinoma in situ evolving within it. It's more commonly seen in patients that are HIV positive, really common in that setting. Clinically, it usually looks kind of like a brown cluster of papules forming a plaque. It does tend to be kind of brown in color. Here's another area demonstrating the same changes. So this is Bowenoid papulosis. Tends to be somewhat less aggressive overall than other types of squamous cell carcinoma in situ. We often treat this with either local destruction or desiccation curettage, but if it keeps coming back over and over again, it can lead to invasive squamous cell and actually cause problems. So if it doesn't go away with destruction, you want to make sure that you go ahead and excise it, especially if the person's immunocompromised. It's a nice example of that. I think we've got a nice clinical photograph of that also. So clinically, they often look like condylomas, so you may have to, if you really suspect it, or you want to confirm it just with a biopsy, you're going to have to take a biopsy to show that it's really cancer, because those look pretty much just like other types of condyloma from a clinical perspective. We have another. So again, notice the things we talked about here, the fact that you've got the atypical keratinocytic proliferation with close crowding of nuclei, the mitoses, and et cetera, that we saw in that actual slide a minute ago. All right, number 162. Okay. There's two pieces on there. Okay. All right, so we've got a punch biopsy. The main action is on this piece of the tissue, not this one. And at low magnification, you can see that there's a neoplasm. You see that there are nests of cells, and you can see there are several different patterns. Some areas they're more heavily pigmented, more closely aggregated, kind of forming a little coalescence of nests here, not really sheets, but kind of beginning to. And then nests again at the bottom, heavy pigmentation at the bottom. We don't have the ability to assess breadth, symmetry, and circumscription, so you kind of have to rely on other features when we just get a punch of a melanocytic lesion that is obviously broader, does seem to mature, seems to be somewhat vertically oriented, so those are things that favor benign. Let's go to higher magnification where we look at the cytology of the cells and make sure that there's no mitotic figures, no necrosis like we had with that unusual melanoma a minute ago. Most of these nests are comprised of typical appearing melanocytes that do not have any mitotic figures or striking cytologic atypia, arranged mostly in nests. This area looks very much like a blue nevus, cellular blue nevus. Cells are somewhat spindle, somewhat dendritic, they're heavily pigmented. That pointer go. Die. Now there it is. Okay, so heavily pigmented melanocytes, somewhat spindle. Talked about the different patterns of melanocytes a minute ago. Notice the absence of mitotic figures. Notice that some of the cells have relatively abundant cytoplasm. So if you took that cell and transplanted it at the dermodermal junction of the so-called dysplastic nevus, it looks pretty similar. Same thing with some of these cells near the base. Right here. So this is a type of combined blue nevus. It's got multiple different patterns. It's got features of blue nevus. It's got features of banal nevus at the top. It's got some of these deep extending nests of cells. So there are a bunch of different subtypes of blue nevus, and one type is a so-called deep penetrating nevus, which is consistent with that variant. It's not perfect for it, but it's consistent with it. So that's more of a histologic curiosity. It's a benign lesion. The most important thing is you don't want to overcall it as a melanoma. It's not melanoma. It's just a variant of a blue nevus. So it's not anything really to worry about. Clinicians worry about it because it's so dark. They think anything dark means melanoma. It doesn't. We have a clinical photograph of it. They look kind of just like blue nevi clinically, so this is fairly nondescript. It just looks like a general blue nevus. So again, these are, usually they don't look much like a melanoma from a clinical perspective, but if there's a clinical concern, obviously you've got to take a biopsy of it. Let's look at the next one. So these are generally symmetrical, usually very vertically oriented, and you'll have the cells that kind of look like the cells of the dysplastic nevus, often at the base of these lesions. Okay. All right, nice example of this entity also. So it's a punch biopsy, nice inflammatory skin disease. And notice that it's got a superficial, mostly perivascular, and interface dermatitis. So a true interface dermatitis, you really can't see the interface between the epidermis and the dermis well. It's obscured by the inflammatory cells. Notice the cornified layer, it's abnormal. It's got some perikeratosis, and it's got some serum in there, and some crust, and with higher magnification, you can actually see some polys in there as well. So even further higher magnification, notice that there are some dyskeratotic necrotic keratinocytes, extravasated erythrocytes, neutrophils, and the crusted perikeratotic cornified layer. So this is just about as good an example of Pityriasis lichenoides that you can get. Now, is it pleva? Is it Pityriasis lichenoides chronica? Is it so-called subacute Pityriasis lichenoides? In my opinion, those really don't make a lot of difference. You can get patients that have Pityriasis lichenoides chronica for years, and suddenly they get a new lesion. You biopsy it, it looks like this. If you have this as a superficial deep infiltrate that's more wedge-shaped with this finding, that'd be classic for Pityriasis lichenoides and varioliformis acute, or mucous disease, the acute form. So this pattern here looks pretty good for the acute form, but usually that's got a superficial deep infiltrate. So I don't like using age of lesions in name. So we just personally would like to just call this Pityriasis lichenoides, because I don't know if this is an acute lesion, somebody's had the process for many years, or it may be a relatively chronic lesion and somebody that's got obvious pleva that's been present for a couple of months. So it's a beautiful example of that because it demonstrates all of the features that we just mentioned a minute ago. There are several different forms in addition to the acute, subacute, and chronic form. There's a type that can be widespread and hemorrhagic, associated with febrile illness, and patients can actually die from this. So it's not always a benign process. One other teaching point, if you see eosinophils in what looks like Pityriasis lichenoides, especially, you might be allowed one, but if you see any more than that, it's not Pityriasis lichenoides. It's either a simulator of it, maybe a drug reaction. Make sure it's not lymphomatoid papulosis simulating Pityriasis lichenoides, because that can simulate Pityriasis lichenoides histologically, and you can get plenty of EOs in that. So, nice example. And the scale of this, it's a scale crust. It's a wafer-like crusted cornified layer. It's adherent. It's not branny like you see with something like tinea versicolor. This is a adherent scale crust. I think we got a couple of pictures of this too. Yeah, notice, look how crusted those things are. So if you went over there and tried to pluck that off, it's not going to come off easily. It's going to leave a red, eroded area. So, again, clinical, they're often in different stages of evolution. So again, you can call it pleva, but I just like to call it Pityriasis lichenoides. And then the treatment of this is tough. Things like tetracycline, really bad cases, you may need to use methotrexate. I don't know if anybody's ever tried a biologic on this, but it might be interesting to see if that would work, especially in some of the severe forms. So, nice example. It talks about immunofluorescence. That is probably largely maybe the background staining. It's not really an immunofluorescence positive disease per se. So you sometimes can get lymphocytic vasculitis. It's one of the few conditions you actually get a true lymphocytic vasculitis, and it's relatively uncommon, but it can happen in Pityriasis lichenoides. Okay, a couple more in good shape here. All right, punch biopsy that goes all the way to the fat. So this is a stellar biopsy, especially if you're dealing with something in the fat. So if you take a punch and you hadn't had worked out recently, and you just kind of get to this level, you're not going to get into the fat. If you biopsy panniculitis with a punch, you need to push it all the way to the plastic. You stick it way down in there. Because if you do a superficial punch, maybe problematic, and if the fat's degenerated, even if you go down pretty deep, you may just pull it up and all the good stuff is left behind and you don't actually get the pathology. So we get a lot of biopsies of panniculitis by punch that are inadequate. So it's better if you can take an incisional biopsy. And notice that this is a panniculitis. The dermis is unaffected. And so we talk about panniculitis. We talk about lobular mostly, septal mostly, combination thereof. Is there vasculitis or not? What type of inflammatory cells are present? So those are all the things we look for. We won't go through the entire algorithm today, but you can see that this is a mostly lobular panniculitis with some very lobular abnormality of the septa here, but largely lobular panniculitis. And all of these areas here are what we refer to as fat microcysts. These are not lipocytes anymore. These are analogous to the alveoli in people that have emphysema in their lungs. These things coalesce and form these large blebs here. And this also demonstrates a very characteristic membranous fat necrosis. Beautiful. A little bit of dystrophic calcification, not a lot. And then you get the sclerotic collagen, which goes along with this. Notice the relative paucity of inflammation. A little bit, but not a lot. And the inflammation that's there is probably just secondary to fat degeneration. It's not really a primary inflammatory panniculitis. This is a manifestation of chronic stasis alteration, and if you look overlying the panniculus, you'll almost always, in fact, virtually 100% of the time, not always, but almost always, see evidence of stasis change. Now, when might you not see it? Well, let's say you had somebody that underwent a cabbage, and actually had a bypass graft taken at the site, and they got altered circulation. I've seen a couple of cases over the years of those patients getting sclerosing panniculitis or hypodermitis sclerodermiformis. So, but 99.9% of the time it's due to stasis. And clinically, it's manifest by this inverted Coke bottle, champagne bottle, which we have a picture of over here, pattern. If you get this early, you may just see a localized area of erythema that's almost looks like a plaque that's firm and red. With time, it eventually leads to this. And next slide, we'll talk about the pathology. Now, somebody talk about androgen medications are used. I personally have found that the use of Plavix and the platelet inhibitors works way better. I've got several patients I've treated for years with that, doing extremely well. So, classic finding, probably the second most common panniculitis we get biopsy. The most common is rheumatoid erythema nodosum. This is the second most common. Okay, the last slide. Another nice inflammatory disease, low power. We see a superficial perivascular dermatitis that may be extending to the mid-reticular dermis with interface change again. So we've had a couple of interface dermatitis today with a little bit of spongiosis. And notice the cornified layer here. This does not have the cornified layer that the Pityriasis lichenoides case had. It's got basket weave, so it means it's probably not even scaly clinically, no crust, nothing like that here. Nice interface dermatitis with lots of dyskeratotic keratinocytes and infiltrative lymphocytes. We notice also some neutrophils and also some occasional eosinophils here. There's an eosinophil in the epidermis right there at the DE junction. Here's another one over here. So mixed infiltrate with eos, interface dermatitis, lots of dyskeratotic keratinocytes, some areas of spongiosis, which you see in this condition. This is an example of a fixed drug reaction, fixed drug eruption. Now, usually that's superficial and deep. And because it usually occurs over and over again at the same site, you'll often get melanophages that occur relatively deep here. Here's a little bit of a slightly deeper infiltrate here. It's subtle. But unfortunately, our examples of these diseases don't always read the textbooks, so this one, unfortunately, didn't give us a deep infiltrate, didn't give us the deep melanophages. So, again, we're looking at a interface dermatitis with mixed infiltrating the eosinophils and dyskeratotic keratinocytes. So this is a nice example of fixed drug eruption. So let's take a look at the clinical photo. So here's a nice example. Often the penile area is a common site of involvement. Drugs that cause this, phenolphthalein is a common one. There's a number of drugs that you should be familiar with, knowing which ones are associated with this. We've got another photo here. So again, you've got to take them off the medicine to get this to go away. Next slide. So the differential, again, just looking at interface dermatitis, erythemal deformity can look extremely similar to this. So that's probably not one unless this really was a classic superficial deep infiltrate that you'd be expected to distinguish between, because this one and EM could look similar. Usually more EOs in fixed drug than in erythemal deformity, but you can occasionally get a few EOs in erythemal deformity. Okay, we're just about done. Comments, questions, criticisms, eyes hurting?
Little break.
All right, very good. Thank you all for tuning in. We'll see you next month for a lecture next month. All right. Did it pretty much on time? All good?
Yeah, no, it sounded great. Looked good too.